Today I want to talk about one of the most common misconceptions in thyroid medicine, in my opinion. Why TSH isn't everything, why normal TSH doesn't always mean you feel well, and why sometimes an abnormal TSH doesn't always need treating. So first of all, let's start off with what a TSH is. TSH stands for thyroid stimulating hormone. It is a pituitary signal. It is not a thyroid hormone itself. So in other words, the TSH level is reflecting what the brain is asking for of the thyroid, not what the thyroid's actually doing. It is not a measure of T3 hormone at a tissue level. What it is a good screening test for the general population. But that's for people as a mass, not those of us who have thyroid issues. So why can a TSH mislead? The pituitary itself is protected from cellular conversion of T4 to T3 issues. So the pituitary has its own deiodinase enzyme in it, and that converts unusually well T4 to T3, no matter what the circulating tissue levels are. So it is, to a certain extent, protected in the body until it isn't, and we'll come back to the until it isn't in a minute. So therefore, small amounts of T3 medication going directly to the pituitary can suppress the TSH disproportionately. TSH rises when the pituitary protection is finally overwhelmed. In other words, when the T3 is so low throughout the whole body, eventually you may get a raised TSH, even in the context of a normal T4. But symptoms will often appear long before that. So the myths. TSH is normal, everything's fine. You probably know a lot of these. Symptoms can't therefore be thyroid related. You must be depressed or anxious or making it up or just overweight or tired because of life, or I mean, you name it, I've heard them all, as I'm sure many of you have. Your TSH is normal, so you don't need other medications. TSH less than 1 is dangerous, when actually, especially on levothyroxine treatment only, you're aiming for a TSH to be below 1 generally. TSH and T4 are normal, you're fine. TSH is high, but T4 is normal, you're fine. Or TSH is normal, TSH is high, T4 is normal, but hey, let's increase your T4 anyway because the TSH is telling us we must. And often that actually leads to worsening symptoms. TSH is high, you must be hypothyroid. Without the context of patient's symptoms and the patient's scenario and everything else, also actually quite dangerous, especially if it's somebody with eating disorders. A TSH will automatically go high, but giving them something like levothyroxine can actually make their eating disorder a lot worse. You have high antibodies and symptoms, but your TSH is normal. You do not need treatment. That's possibly one of the most common scenarios I see in this clinic. So in other words, you've been diagnosed with Hashimoto's, but your thyroid's showing is fine, so we're not going to do anything. So I'm going to stick with the sort of treated scenarios for the most of this conversation. We will come back to the Hashimoto's and no treatment. So if you're on treatment, why, and you've got a normal TSH, and let's say that a T4 has been tested and you're told that you're fine, but you don't feel fine. So why not? The most common reason for this is that you are not converting, or your body is not converting, your levothyroxine, your T4 storage hormone, into the active hormone that is T3. You may also have too much T4, too much levothyroxine. So again, going back to the sort of fire or central heating scenario, if we have a fire and it's got fuel, and then we put even more fuel on it, more logs onto that fire, it can actually put it out. And that is sometimes what happens when we give too much levothyroxine. is the body, the pituitary, senses that too much, and it starts to convert that T4 into something called reverse T3. And reverse T3 is an inactive form of active T3, and it actually can block active T3 at a cellular level. So you may feel worse if you've got too much T4, and sometimes all I need to do in clinic is reduce down somebody's levothyroxine, give them some thyroid-friendly supplements, and they feel a lot better. You may have other illnesses going on that are affecting your conversion rate. Sex hormone changes, massive. And by sex hormone changes, I mean in and around puberty, in and around childbirth, in and around menopause or andropause. So that big change in sex hormones causes an internal stress on your body, and that in itself can affect conversion. Also, especially in women, estradiol and progesterone have a very, very complex relationship with thyroid hormones, and they can directly affect a T4 to T3 conversion. Another reason why symptoms might persist is in conditions like polycystic ovarian syndrome, you can actually be thyroid hormone resistant, especially T4. So why is T3 important? T3, and the number of times I will have said this and will continue to say this, T3 is the active hormone that works. It is what you need to feel well. Therefore, testing a TSH alone or a TSH and a T4 does not actually give us any indication of the levels of the actual active hormone. So every time we in the thyroid clinic are seeing a patient who's on thyroid hormone, even if they're not on thyroid hormone, we will test a TSH, a T4, but most importantly a T3. Most importantly a T3. If I were only allowed to test one of them in any one test, I would test a T3 over all of them. And then I've written in brackets there, and antibodies if they've never been tested. So I want to know if it's Hashimoto's, an autoimmune condition. But that doesn't need to be tested every time we're testing thyroid bloods. So why can conversion be variable? We've sort of talked about this already. So other illnesses. For example, if you have just had COVID or a viral illness, your conversion rate might go down during that time. So you may find that if you come see me and you say, oh, I've had COVID and your bloods are looking a little bit off, I quite often say, do you know what, let's just leave this for a month. How are you 3 months? How are you feeling? If you're feeling hypo, we may even increase. If you're feeling hyper, we may decrease just for that limit, just for that amount of time. And then we reassess once COVID's well and truly out of your system. Stress. Stress causes huge conversion issues. Not always things that we can do anything about either. You know, stress is just life. So just because we say stress is causing conversion issues, doesn't mean you need to de-stress, meditate, do yoga, whatever. It may just be you and your general cortisol levels, adrenaline levels, your autonomic nervous system. And if quite frankly that what we need to do to make you feel better, even to get that stress out of your system, is to give you a little bit of T3 containing medication, even if just for a little bit, we will. My view on treatment is always what we've got is where you are now. We'll deal with everything else as we go along. Inflammation can cause difficulties with conversion. Calorie restriction, going back to the eating disorders. So actually your body will go into a state of famine. It will hold on to everything. And by going into that state, it holds on to your T4 stores for dear life, and it doesn't want to convert that T3 well. Because it doesn't want to burn off too many calories. So actually calorie restriction itself can really mess with the thyroid. It can also make you produce more reverse T3, which is why I tell my patients not to fast. Sex hormone changes we've already talked about, so that change in estrogen, testosterone, progesterone. Genetic deficiencies of deiodinase, so big one actually. Deiodinase are the enzymes that help us convert T4 to T3. Why is that important? Because if you don't have the enzymes, you won't convert well. I actually have a deiodinase deficiency, so not only do I have Hashimoto's, but I also have that deiodinase deficiency. So I even more need T3 medication. Autoimmune thyroid disease, the reason that's on there is because eventually those thyroid antibodies will sadly pretty much destroy your thyroid. Now, your thyroid, as I have said many times, produces 5 hormones: T4, T3, T2, T1, and calcitonin. Now, those T2 and T1, they still sit there being very unresearched, but one of the things we do know is that they do affect conversion of T4 to T3. So if you're lacking in those, you're lacking in something to help you convert T4 to T3. In other words, if your thyroid can't produce them, it's not helping that conversion of T4 to T3. But also your thyroid produces some T3. It produces about 1/8 of the circulating T3 in your body. So if you've already lost that as well, and your T4, you are completely reliant on that replacement of levothyroxine hormone, T4 hormone, to be converted in your peripheries to T3. You've got nothing in the background to help that conversion that's coming from your thyroid. Therefore, the same with a lack of thyroid. If you literally don't have a thyroid at all, through thyroidectomy or radiation, you're locking all those 5 hormones again. This should have been a myth, really. Low TSH does not equal danger by default. Context matters. Symptoms matter. If you're on T3 medication, it suppresses the TSH more than levothyroxine does. A low TSH, all it means in the context of a normal T4 and a normal T3 means the pituitary is not driving that thyroid anymore. Essentially what we are giving you, the hormone replacement, is. Why do context matter? Why do symptoms matter? That's because not everybody likes to have the same level of T4 and T3 hormone. So for example, me, I prefer to have a T3 that sits around 5, despite the fact that I know that most of my patients like a T3 to be between 5.5 and 6.5. So individuals matter, symptoms matter, and your context matters. So I think the best way of explaining things is through cases. I went to a medical school which was very case-based, and that really suited my brain. So I hope this suits yours too. So case 1, menopausal woman. Alarm bells already. Long-term levothyroxine generally feels unwell. Now let's assume in this context, I haven't put too much detail in this, but let's assume in this context that HRT is on board. She's doing well on that. Still on levothyroxine, just not feeling quite right. We do some results. TSH is normal. Let's say it's, I don't know, 1.2. T4 is 18, 19. So again, normal. T3 is 3.3. She's been on levothyroxine for many, many years. She's postmenopausal. She has persistent symptoms. What's going on here? So we don't know if she's got antibodies. I'm going to skip over antibodies for the moment. That's a topic for another conversation. But it's obvious that she is not converting well. So when I would look at the numbers, I would do a ratio of T4 to T3, and that should be at least 4:1. So let's, for ease, go for a T4 of 20. I would expect that T3 to be at least 5. In her case, I think I said it was 18 and 3.3. So we're looking at an increased conversion rate. That conversion rate is way above 4. So what do? We can add in some T3, we can switch on to ARMA. But the point here is that that TSH is normal. That T4 is normal, but the T3, the active hormone, is not. The active hormone is positively low. That's why she's feeling unwell. If we didn't test that, we would never have known. Case 2, 60-year-old man with Hashimoto's. Hashimoto's means he had positive antibodies. So he has a high TSH, a normal but slightly high T4, a low T3, positive antibodies, and he's symptomatic. So in this case, this is going back to what we were talking about the pituitary not having enough. So in this case, the TSH has become high. That would indicate that that low T3 has been going on for many, many years, to the point where now even the pituitary isn't protected from circulating low T3 levels. So again, we need to look at some T3 medication. That's why he's not feeling well. Chances are, if he's still got positive antibodies, he probably has a burnt out thyroid. May also have been that he went through andropause, so he had a testosterone drop, I don't know, 10, 15 years prior, and that was also part of when that conversion rate went off, and he's then been living with that low T3 for many, many years. Case 3, 18-year-old with anorexia. TSH is high, T4 is low, T3 is normal, antibodies are negative, significant calorie restriction. So here we go. This is your kind of patient who does not necessarily need thyroid input. And actually, I remember about 2-3 months ago, I think I put up a case study on Substack where I had exactly this scenario and another lady with a normal TSH who would not have been treated in NHS in my clinic. And probably contrary to what most people have done, I treated the lady with the normal TSH and the antibodies and lots of symptoms. I did not treat the 18-year-old with a high TSH, negative antibodies, and essentially normal T3 and T4. Why? Because if you're significantly reducing your calorie output, you will cause a high TSH because your body wants your thyroid to produce more and more and more so that it can hold on to everything, keep you in famine mode. If you start to treat, they can feel worse. You can actually expedite, that's not quite the right word, but you can make their weight loss worse and accelerate their anorexia and weight loss. Here we go. So patient with positive antibodies, biochemistry is normal. I haven't put an age in this one, so let's assume that they're, I don't know, 25, trying to get pregnant. Normal TSH, normal T4, normal T3, sky high antibodies, very symptomatic, can't get pregnant. For me, I would treat. Why? Because we know she has a thyroid disorder. We know she has Hashimoto's. We know that she is describing symptoms of hypothyroidism. So she can't get pregnant. Let's say she's been putting on weight. Again, this is where context is so important about what symptoms is she having. What we know is that with treatment, it can stall or slow down the progression of Hashimoto's. It can massively improve symptoms. And actually, one of the things I see many times is that T3 and T4 that you would expect if we started treatment to go really high actually stays in that normal frame. But the patient starts to feel better. And that's because they have something called a down-regulated HPA axis. Their body has literally turned down their thermostat and they are running cold. But it still looks like on the surface of it, they're okay. That's something we will definitely go into in another time. It's far too complicated to describe in a couple of sentences. Case 5, 45-year-old woman, Hashimoto's, on T3 hormone containing medication, feels well. Probably a patient of the thyroid clinic. She has a suppressed TSH, a normal T4 and a normal T3. I've put there she's on Armour-thyroid. She may be on liothyronine and levothyroxine. She is asymptomatic. She feels well. So that T3 hormone is suppressing the pituitary. Not in a bad way, because her T3 and her T4 are normal. Just because what it's doing, exogenous T3 hormone, external, is saying to the pituitary, okay, you've got everything in your blood that you need. You don't need to stimulate your thyroid anymore. If her T4 and her T3 were high and her TSH was suppressed, at that point I would say, okay, we're probably a bit overtreated, let's reduce it down. That's when the danger of atrial fibrillation and osteoporosis comes, not in the context of a normal T4 and a normal T3. So let's pull all of this together. What actually matters in our opinion? In our opinion, it matters how you feel. Almost that above anything. However, your free T4 and your free T3 also matter. And that's because I want to make sure you are not overtreated, because that has dangers. But also I want to make sure that you're not undertreated for you. Because if we can make you feel a little bit better, why would we not? So those are really important. Your patterns, your overall view, what's been going on in the last year with your blood results. When did you feel good? When did you not feel good? Everyone is different and no one lab result fits all. So the takeaway points distilled down into two very simple sentences. TSH, thyroid stimulating hormone, tells us how the pituitary is feeling, not how the body is feeling. Free T3 is essential in assessing thyroid hormone treatment. I hope that's been helpful.